review on the maxillary landmarks, anatomical landmarks that we're going to see in radiography, okay? So the two really most important pieces here are knowing what's going to show up in an X-ray as far as what would be defined as radiolucent and versus radiopaque, okay? So we're going to split every anatomical landmark with, are they radiolucent or radiopaque? So we'll talk about the structure, where they are. We're going to separate them between maxillary and mandibular. Now, the big reason why we need to know anatomical landmarks, obviously dentists need to know for anatomy purposes, like diagnostic. But for us as doing radiotech, like radiology in our domain or our scope, is to know if the quality of picture is accurate, right? Can they see the radiopaque and the radiolucent, as well as did we take the right or correct picture? Do we have the right tooth? Do we have the right area? Are we in the vicinity to what we need to be? So that is essentially why anatomical landmarks are important for us as assistants, is for that reason. However, we also need to define what structures are in these because of charting, right? If we're going to chart what's an existing filling, is it an amalgam filling? Is there an implant? Is there a crown? So we do need to have an idea of what the charting is, or look at it so that we can preemptively chart and get confirmation in mouth from the provider for us to finalize that. So that's the big reason why we're doing this. Now, offline reason why we like to know anatomy is that if somebody's coming in for an emergency and we're like, oh, that's an abscess, let me get some materials out in case the doctor diagnoses this, and we're going to turn and kind of do it right there, we can preemptively set it up. We're not going to tell anybody, we're not going to tell patient, we're not going to diagnose. We're just going to have a sequence of events behind the scenes or an idea of what's going on so that we can be more proactive in setting up for whatever procedure you think that they may do. Okay, so that's like the quiet little version of it's nice to know this, okay? And obviously going to dental school, you'll need to know this. This is part of the world, right? So here, let's first define radiolucent and radiopaque. We know radiolucent is any area that's going to appear dark or black, right? We know that it's going to, why it appears that is because the X-ray that passes through does exactly that. It passes through. So any kind of radiation that passes through something is going to show that gray or that black or that dark area, because it's not going to bounce that radiation off. It doesn't capture it. It just goes straight through. Nothing's hindering it. Nothing's holding it back. What radiolucent areas are sinus cavities, so airspace. Any airspace is going to be that dark or black space. Soft tissue, so gum tissue, is going to show radiolucent. Periodontal ligament, the ligament, that tissue that is, again, soft tissue. So any gum tissue, periodontal ligament, pulp, the pulp chamber, that all of that, anything, again, tissue based, is going to be that dark and black. So if you forget, go by definition, it's a tissue, it's going to be radiolucent. And less dense bone. So what would be less dense bone? Your maxillary has less dense bone. And sometimes some parts of the mandible will have a less dense bone. That we'll see, like canals where blood supply goes through, things like that. We'll see it as that radiolucent space. Okay. With that being said, I also want to talk about holes in bone. Okay, so what are types of holes in bone? Foramen is a hole in a bone. So when we say something like mental foramen, that means, which we're going to see shortly in the mandible, that means there's two holes that are in bone. And why do you think we would have holes in bone? Two reasons. One, to create airspace for things like sinuses, depending on, if it's in the maxillary, or if it's something in like a more solid jaw, like the mandible, it's going to be where blood vessels and nerves can innervate through, right? How do we know? How do we innervate nerve to parts of your jaw? Where does it come from? How does it get there? These mental foramens, the little holes in bone that they can travel through. Kind of makes sense, right? So anything that you see a foramen is a hole, okay? And that's going to be airspace is going to go through blood vessels, tissue. It's a nice little, and anytime you hear the word canal, radiolucent, it's going to be something's traveling through, okay? Does that make sense? Kind of break it up. Good. Now, radiopaque, direct opposite. That's going to show that real white or even a light gray. Now here, it's going to block the x-ray from going through and it kind of imposes on it, right? It bounces off of it. So it shows up that real white or light gray. Things that, anatomy that shows up would be your dense bone. So you'll see that real highlighted light gray show up in jaws, enamel, dentin, any restoration, amalgam, composite, an implant, a crown, all of that is going to show radiopaque, as well as for an endodontically treated tooth or root canal, we put something called gutta percha in the roots, which is like a inert rubber material. So that's also going to show those like really white spaces.
On an X-ray, is a cavity also shown as white, or is it
No, the
it's
direct
opposite?
opposite. It's air. So a cavity, what is a cavity? It's an empty space, right?
Yeah.
There you go. So that's going to be radiolucent. An abscess is going to show radiolucent because the abscess ate away the bone.
Yeah.
Got it, right? So anything that's missing something is going to be that radiolucent, that dark. That's a great question. And I'm sorry I didn't mention that there. Think of it like this. Cavities, the bacteria eats, like removes tooth structure. So it's empty. There's nothing in there except dead tissue. Again, tissue, radiolucent.
Mm-hmm.
Okay, cool. So let's talk about the first maxillary landmark. So the first one is our incisive foramen. Incisive means it's by the incisors. And we talked about a foramen, that's a hole, right? So here we have a hole right by the incisors, right? Dead center. Why? Because we're going to innervate with blood supply and nerves right there. So that's what's happening there. Here you can see a really good picture. I'll draw, let me do this. I'll draw it. This is the incisive foramen. Do you see that where that hole would be? I drew in blue.
I can't really see like anything you're drawing.
You can?
Yeah, I
Oh
can.
my God, I'm not sharing my screen.
Yeah, I was just going
What
off
in
of
the
like
world? Why are you not telling me? Oh my God.
Okay, now I can see
Oh my
it.
God. I thought yeah, so sorry. Anywho, incisive foramen is this hole, and it's directly in the center of the two incisors, central incisors. Makes sense, right? I want you to see something else. When we see it in an x-ray, so if we're looking at it head on, like in an anterior over here, so here is this dark, this radiolucent area, that's the incisive foramen. We'll also see it, check this out, right here on this top picture. So this is actually a maxillary occlusal picture for an adult, not child. And how I know it's an adult is because all of these molars are in. This is a pretty big picture, right? This is a size 4 film. So this is a large picture. This is where the incisive foramen is, right in that area. Not that we're noting it here, but you see this big black area here? That's an abscess. This, do you see that? Yeah. This white part is actually a post on a root canal tooth. Okay? These are all amalgam fillings here. So these are showing radiopaque, and then you have your nice radiolucent issue. You can actually see the maxillary sinuses as well. This black part here, this black part here, okay? And I can also see the base of the sinus, like the bone, like, so sinus is the airspace. The bone would be called the sphenoid or the ethmoid bone. Okay, that's the floor of the sinus. Do you see these white areas right here? The radiopaque, that's the thicker bone. That's the floor. It's just heavier there. Do you see this big white hook, Jay? That's the cheekbone. Oh, weird when you look at it upside down, right? You're looking at it from actually not upside down, but well, you're looking at it from under, from inside the mouth, like from this way. So it looks a lot different, but just so we're aware, radiopaque, radiolucent. You see a lot of dynamic here. Okay. Any questions on that? Does that make sense? Okay, good. Again, just showing incisive foramen. Again, the hole right there. Oh, here's gutta percha. This is gutta percha on a root canal tooth. This guy right here. So it shows radiopaque. Cool. So again, incisive foramen showing radiolucent. It's a round oval dark area. It's located maxillary between the central incisors, and it's surrounded by a thin radiopaque border. That's how we tell, right? And what is the radiopaque border? It's bone. It's just a collection of bone cells. That's why it's showing that radiopaqueness. That's all, okay? Location, midline, it's by the apex, the apical of the central incisors, and it can be mistaken of like a periapical pathology. That's what we saw here because it's so close. If you're not looking correctly, you're like, oh, that's just this. It could be a fracture. It could be this. Meanwhile, it's the incisive papilla. So that's really all we're talking about here, okay? And it's usually like, it's very tiny. And again, it's surrounded by that radiopaque border, that thin radiopaque border. Okay, next, we have a median palatine suture. So here's where your anatomy pays off. Your median is directly equal right and left, right? Your palatine is your roof of your mouth, your palate. Okay, your palatine bone. Your suture is where it's a non-movable or an immovable joint. It's where the two bones at your palate come together is a suture. Okay, so when you're looking at this, you can see this is a suture here, and there's a cross suture as well. Do you see those sutures there? It shows up like this crazy line here. It's very definitive here. Why do you think it's definitive there? Look at it. Do you think this is a child? No? You don't think so? So at certain points, right, the sutures take time to close. So in my head, I'm looking at this and I'm like, I think this hasn't closed. So this may be a younger person.
Oh, yeah.
Different, weird, right? And not only that, or it could be that it never closed as an adult. Well, that's a problem Now you're going to look at it, right, and go, oh, look at this huge space between these two incisors. Why? Never sutured. Uh-oh. So can you make it suture? Absolutely. Braces, ortho, things
Yeah.
like that, surgical closures. I'm just stating that because you can see if you're not looking or if it's not diagnostic and if your x-ray is too dark or too light, doctor isn't ever going to see that and see if there's an issue or if it's, oh, this is supposed to be here, or hey, we need to do something. Does that make sense for our version of it? Okay. So again, thin radiolucent line located between the maxillary and central incisors. And it's, again, bordered by a thin radiopaque layer of bone. And it's right at the midline. Cool? So far, so good? Okay. Nasal cavity. Nasal cavity is probably the easiest to detect, right? You're like, oh, okay, this is it. It's the nose. All right, cool. So here, this is just showing skull. We know this is a septum, right? It's the septum. It's it's the breaking of it. It's the division of it. So here, we're going to see that septum here. We see the nasal cavity on both sides. Makes sense, right? It's the air, it's the sinus, it's the nasal cavity. Anytime you hear the word cavity, you're thinking, oh, it's going to be radiolucent, right? Now, just because it's dark here doesn't mean it's an abscess, right? Our location is just, it's a cavity, so it better be dark. If not, that means there's gunk in there, or a polyp, or something weird, right? You'll see it in there. Again, that's what we're looking on. And you can see ever so gently this radiopaque, right? Anytime we have a floor or the bottom of a sinus, we're always going to have that thin line of radiopaque because that's the bone. Again, the names of those bones are the sphenoid bone and the ethmoid bone. And they make up the floor of the skull, which in turn makes up the sinus cavity. A description is it's a radiolucent area. It's surrounded by radiopaque cortical bone, which you can see in that nice little V shape, right? Cortical bone is the thicker type, the more dense bone. Have you had anatomy before? No. Okay. It'll come full circle when that happens. Okay. You'll be like, oh, that's why. Cortical bone is just really dense bone. That's why. That's all. And kind of makes sense. If we have cortical bone that's surrounding in the skull, right? Because most of our bone is cortical bone, but if we didn't have air spaces in sinuses, we wouldn't be able, that vibration, that resonance, it would be like talking underwater. So it gives that, that what's called resonance, that vibration, that allowance of air to travel, to talk, to make sounds. So it doesn't sound like we're talking underwater all the time, that pressure. Okay. Now, finally, maxillary sinus here. So maxillary sinus is, again, you're going to see it all you'll see it straight across the maxillary jaw, okay, from the molars to premolars, and then of course more anteriorly, and then again over the side. It looks like radiolucent cavity, and it again has that curved radiopaque floor. So you'll see the darkness, and then you'll see that radiopaque floor. Typically, sinuses are molar, premolar, like right above that. So all good. Why? Because your nasal cavity is in your anterior. So the other sinuses are going to be in the premolar area and then the molar area. Or we would just be like all holes, right? Like Swiss cheese. We can't have that. We have to have some kind of resonance in there, some sort of stability. Now, your zygomatic process is a really fancy name for cheekbone. Okay, so your cheekbone you see this, it's either shape of a J or a U. So anytime you see this real radiopaque area over the molars, it's your cheekbone. Okay. Again, you can pretty much see it. This is a J shape here. You can see it very little here to U. So depending on the shot, will either look like a J or the full U. It always depends on the angle of what you're taking that. They're both right. It's just depending on the angle. We're not looking at going, oh, you didn't get the full U of the zygomatic arch. Who cares? It's the teeth that we're worried about. We're just using this landmark to know where we're shooting. Okay. So it's a thick radiopaque area, and it's either in a U or a J shape appearance. So again, either one are good. One moment you'll get a U, the next picture you may get a J. And it's typically over the first molar area. Okay. Typically. That's not to say that it is, right? Okay, I just like to say typically. So you may see it over your second molar, first molar. It could be even toward the premolar. It really depends on their facial anatomical landmark, but you'll see them toward the back of it, okay? Okay, that concludes our mostly our maxillary landmarks. Now we're going to get into the mandibular landmarks, so the lower jaw. Now, in general, the lower jaw is obviously much more dense. We don't have a lot of we don't have any cavities there except for one area, which we'll show, but it's very narrow. And it's filled with blood vessels and nerves. Okay, so the first one we're going to talk about is the mental foramen. And like I said before, foramens are holes. Mental means chin, fancy name for chin. So at our premolar, or right in between our premolar, we're going to have these two holes, right and left. Why? So the blood vessels can travel through. Blood vessels and nerves. So when we do a nerve block, let's say back here in the molar area, right, to do a mandibular nerve block, we're going to numb, it's going to numb all the way up to the midline. How, you say, is because this is going to innervate. I'm going to show you something here. Do you see this area here? This empty space here, this cavity? It's empty, right? That's where nerves are, nerves and blood supply again. So if we're doing an injection here, the doctor's doing an injection, it's going to give the medicine here. This travels all the way up and innervates all up to here. That's why you get that nerve block and it stops right at your chin. Does that make sense? With that being said, let's say they're just numbing up the anterior, like the front part of the teeth, like right here. They can do a mental block and innervate right here. Do the injection there to get this part of the chin. Makes sense, right? That very anterior in between the two incisors kind of chin area. I'm just giving you kind of like why they would use that before, why we have to make sure we see it. So anyway, mental foramen is the chin hole, as I like to call it, and that's where we're going to have a radiolucent area. It's at the premolars, and we want to recognize it so we know it's not pathology, and it's going to be near the apices or apex of the two mandibular premolars. So that's the location. Okay. Now we just kind of reviewed the mandibular canal, but here it is. So the mandibular canal, it's actually, it's that area right here. Do you see that empty space? You see this white plate? Hard to see a little bit, but it's marked by that radiopaque area, and then the inside's the cavity. So it's almost like a mandibular jaw, like I'm going to use the word sinus because it's the floor of the bone is a little bit thicker on both sides to house, so it protects the nerves and the blood supply. Think of it that way. Okay. Here we see a dark radiolucent band, and it's bordered by the thin radiopaque lines, and it's going to extend from the mandibular foramen to the mental foramen. Again, mandibular foramen here, so that's a hole in the mandible, again, where we're going to innervate for injections, and then it goes directly to the mental foramen. So cavity is going to travel hole to hole. Yeah. The external oblique ridge. So external means we're going to see it. It's going to be a thick area of bone. Okay, so anytime you hear the word ridge, process, protuberance, bone. It's going to be radiopaque all day long. Okay, any kind of anatomical name for bone, again, ridge, protuberance, process. It's a bone. It's a shape of a bone. It's bone. Okay. Protuberance is like a rounded part of the bone. Even fossa. A fossa is a dip in bone. A ridge is literally a ridge in bone. So here, it is this area of bone here that's going to show as this really thick. Notice how it's on top of the mandibular canal. Makes sense? That ridge is protecting the canal, so to speak. That's how I remember it. Because it's protecting that canal, because that canal has what? Blood supply and nerves. I need it to protect something. So it's doing that. So external oblique ridge is going to be that thick type of bone, radiopaque line, and it's superior to the mandibular molars. This is a nice picture that I have here. If you can, let's look at this big pan. So this is a panoramic X-ray, right? So remember I said fossa. Submandibular fossa, again, is just like a depression in bone. That's all. So it's just giving us that. I'm going to come back to the lingual foramen. Again, it's going to be a hole, okay? And genial tubercle is just going to be like a collection of little bony dots. I'm going to show you that in more depth in a slide or two, okay? The internal oblique ridge is, so the external oblique ridge would be out here. The internal is on the inside, okay? But do you see that radiopaqueness right here? That's the oblique ridge. Oblique is something that's coming off to the side like this, like your oblique abs are the side. So anytime you hear oblique, it's off to the side. Okay. Maxillary sinus, your nasal septum, and your zygomatic process. Not a good picture for that because pans are weird to see a cheekbone because it's going to be higher because it's getting straight on, whereas like a PA is coming on a different angle. That's why you would see it in one and not the other. Okay. Submandibular fossa is what we were just talking about. So a submandibular fossa is a broad radiolucent area. And I'm trying to, submandibular fossa would be this, again, that darkened area down here. Here, okay, here's the genial tubercles. I just want to say that was my last slide. So basically, like tubercles are like little bony protection. So that little bony bony protection around the lingual fossa, okay, or lingual foramen. So there's a hole. So you see the black area dead center. It looks like a black hole and then the white around it, right? That the hole is the lingual foramen. So that's where your nerve to your tongue goes through or innervates into the inside of the mouth there. The tubercles are that are have grown around. Can't feel them, can't see them. It's just
You're like cutting out. I can't hear
oh
anymore.
my God, you can't? Oh my God, is it my internet?
Okay, now I can hear again.
Oh my God, I'm so sorry. Let me know. Okay, I'll just do that over. I'm so sorry. So the genial tubercles are basically little overgrowths of bone that surround that lingual foramen, that hole where the nerves and the blood supply go in. Okay, and feed the lingual portion of your tooth, of your mouth. Um, and that's it. So it's the ring-shaped genial tubercles, ring-shaped radiopaque bony structure. And then your lingual foramen is the radiolucent dot directly inside. That's all we need to know about that. Good. Now, those are the majority of my anatomical landmarks, okay? The bigger takeaway is knowing what's showing up radiolucent versus radiopaque. That's the biggest thing. And to be able to identify some of them, especially sinuses and abscess and cavities and kind of know where we are in that. The zygomatic process, your cheekbone, your external oblique ridge, things that are going to be like, hey, this is showing me where I'm at here, what's going on. My landmarks are showing exactly where I need to be in the picture, if that makes sense. So with that being said, that's the anatomical landmarks. On Thursday, I'm going to send the PowerPoint tomorrow or Wednesday when I get it within the next 24 hours for the Thursday chapter, which is going to start the more detailed of like taking a full mouth set of x-rays. Where do we place it? Like things like that. The rules of what actual we're taking x-rays. What are our rules? What techniques are we going to use? Okay. It's like the biggest part of the chapter. It'll take us a couple of days to get through it. Do you have any questions about this before I go on? Awesome. All right, my dear. Well, Thursday we'll same bat time, same bat channel, and I'm gonna just shut off my recording.
What chapter are we doing on Thursday? I'm kind of like, I think
It's
it's
okay.